Hello, everyone. Thank you for joining us for today's webinar. My name is Dana Burnett, the Managing Director for Worldlink Medical, and I'll be moderating today's event. I'd like to mention a few quick items before we begin. First of all, make note of the features available to you within your WebEx internet browser. In sort of the upper middle right corner of your screen, you'll find two arrows, one facing up and the other facing down. Click on this to view the presentation in full screen mode. And then in the lower right corner of your screen, you should see the Q&A box where you can enter your questions for Dr. Rouzier. They will be answered at the end of the presentation as time allows. The chat box is also available for you if you have any technical questions or comments. Simply select the host and questions will go directly to someone that can assist you with any technical issues. This web conference is brought to you by Worldlink Medical. We provide evidence-based CME-accredited education in preventive medicine and age management with a focus on bioidentical hormones. Feel free to visit our website for additional information on course offerings and dates for 2016. I also wanted to mention that this will be the first of a 5-part webinar series on testosterone, and we'll be exploring other areas, including, the use of estrogen that causes MIs, testosterone causing polycythemia that causes MIs, and testosterone causing blood clots, a recent FDA advisory. So we'll definitely keep everybody up to date on this, but wanted you to be aware that this will be part of an ongoing series. Today's event is sponsored by MedQuest Compounding Pharmacy, specializing in quality preparation, supplements, and services to assist physicians and patients to live a better life. We so appreciate their educational support for these webinars, as well as other Worldlink Medical educational initiatives. Dr. Neil Rouzier is pioneer and a recognized leader in bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life's work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He lectures worldwide, having just returned from Shanghai and Toronto in the last 10 days. He is also the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It is my privilege to welcome Dr. Neil Rouzier for today's webinar from his hometown in Palm Springs, California. Hello, Neil.
Hi, Dana. Hi, Chris. Hello, everyone. Isn't Photoshop a wonderful thing? Is that really me in that picture? Well, the intent of the webinar today is to try to dispel some myths about testosterone. The purpose of it is severalfold. Let me go through the different purposes. Number one, I'm constantly having to deal with my local cardiologist where I work, in that they are, of course, smiling and happy that testosterone has been shown to cause heart attacks. And, of course, they now chuckle and say, that no one should be taking testosterone because it causes heart attacks. It's just interesting how such little minds will take two lousy studies and concoct it into a reason why everyone should stop testosterone. So part of this is to explain to the cardiologist, and I give these articles to my cardiologist, trying to explain to them that no, testosterone does not cause heart attacks. In fact, it's just the opposite. It protects against heart attacks. And if you think that it does cause heart attacks and you take patients off of testosterone, it will actually be increasing their risk. And secondly, of course, our patients' concerns, because the patients will then call in and say, well, my doctor says, well, here, read these articles for yourself. I've underlined the articles so that it's easy to read and comprehend, and then give these articles to your doctor to sort of explain to your doctor that what he suggests is not correct. So I use these articles both for physicians as well as for patients to try to educate them further that no, testosterone does not cause heart attacks. In fact, testosterone is very beneficial to protect against heart attacks, exactly what we've been teaching and preaching for the last 50 years. And now sort of for the bad news, and I've had some criticism about doing this in that I might scare physicians away from prescribing testosterone, whereas on the other hand, my intent of presenting these articles is to further give credence as to why we do what we do and to give confidence to those physicians that are doing it and not stop based on a fear of their peers or perhaps a fear of patients. But nevertheless, there are a couple of cases that I'm involved with that I've had to defend in which the patients unfortunately had MIs or had deaths, and they were on testosterone. And of course, if someone dies on testosterone, we're going to blame the testosterone and blame the doctor for their death. And I've had to deal with a couple of those cases, and I'm going to reference the defense that I used for those cases so that everyone sort of gets an idea and appreciation of what I do and why I do what I do, and to have this in the back of your mind in case anything like that ever happens. But nevertheless, I think it's important for everyone to have a good understanding of this data to be able to defend to physicians as well as patients that what we're doing is in their best interest. So this first article here talks about the impact of testosterone deficiency in men, and that total testosterone may be directly responsible for approximately up to $500 billion of adjusted U.S. healthcare expenditures. Well, that's impressive. Testosterone may be shall we say, testosterone deficiency may be a significant contributor to the adverse public health. And if it truly is, then every one of us should be prescribing testosterone to help prevent that. Further study is needed, of course, because everyone claims that the studies that we quote are not powered enough to show testosterone has a protective effect, but 50 years of studies, hundreds of articles that demonstrate the importance of testosterone in protecting against heart attacks and cardiovascular disease is important to understand. But nevertheless, the FDA has now said, all right, we need more studies. Okay. Anyway, further study, of course, is needed to define exactly the role of testosterone as a modifiable factor for cardiovascular disease, diabetes, and osteoporosis and fractures. This may represent an opportunity for nationwide public health initiatives aimed at preventive care. And, you know, when the Women's Health Initiative first came out, I had to spend a lot of time trying to explain to patients and doctors that, no, that one study does not negate 50 years of prior studies showing benefit. And now that the smoke is cleared, now we're starting to see everyone go back and prescribing estrogen again, realizing that one study does not negate 50 years of prior studies, and that most recent studies since the WHI have showed benefit to estrogen. And I'm sure that the same will occur with testosterone. But nevertheless, we have to sort of go through this painful learning curve. This is a nice summary article. Headlines News in 2013 parroted a study proclaiming that aging men using testosterone drugs suffer greater heart attack risk. Well, it's interesting that the media jumped on this and created significant hype-fomenting hysteria and negativism about it, that now heart attacks are caused by testosterone, whereas the last 50 years of great studies showed that it did not. But everyone sort of forgets that when there's one negative study. The study suggests that testosterone therapy may increase the risk of death in certain cardiovascular events, meaning MI. However, there's several significant shortcomings to both of these studies that I'll review later in this lecture, to their design and to methodology, and really they should be ignored and thrown out. But of course, negativism breeds sensationalism, and as a result, everyone thinks that these studies are great, but we'll look at how significantly poor these studies were, and yet we ignore all the significant data over the last 50 years that show benefit. So the results of these two studies conflict with an existing body of research, and the media's portrayal of this flawed study may discourage aging men from properly restoring their testosterone levels to optimal and potentially endanger their health if they don't. So now we're starting to see a pushback from these two studies. Unless men replace their diminishing testosterone, they could succumb to any number of numerous health problems related to low testosterone, which include frailty, loss of muscle, increase in fat, increase in weight, impaired cognition, Alzheimer's disease, fatigue, loss of self-confidence, depression, mood swings, loss of bone, osteoporosis and fractures, and of course increase in diabetes, strokes, and cardiovascular disease. So when you look at the other side of the coin, which is rule number 3 of my lectures, look at the other side of the coin. Is what we're doing harmful? No, not based on the majority of the literature. if we stop it, is it harmful? Yes, absolutely. So when you look at the other side of the coin and look at what happens when we don't do it, there's significant harm to stopping testosterone or not using it in the first place. So let's look at some of the studies, or shall I say, recent editorials concerning the use of testosterone. This is a nice study that showed that testosterone is not linked to myocardial infarction. Now, for the first time, a comprehensive new study, as opposed to the two flawed studies, shows that testosterone therapy does not increase the risk of heart attacks in men. Remarkably, testosterone was linked with a decreased incidence of heart attacks in high-risk individuals. So the other side of the coin is, no, not only does it not cause it, but loss of testosterone can actually increase the risk. This was a much more extensive study. This study, conducted by the researchers at the University of Texas Medical Branch at Galveston, is the most extensive study of its kind to date, utilizing information from more than 24,000 Medicare beneficiaries, 66 years of age or older, treated with testosterone for 8 years, and appears in the Annals of Pharmacotherapy. The one study that they did that was flawed just looked at men that were given testosterone, but they didn't look at it for a length of time. They just know that they got a prescription for it. And the other study actually looked at it for 3 months, and as opposed to 8 years, which is what we saw in this study. Our investigation was motivated by the growing concern in the U.S. and internationally that testosterone therapy increases men's risk for cardiovascular disease, specifically heart attacks and strokes. This concern has increased in the last few years based on the results of a clinical trial, the TOM trial, which we'll get to and show the problems with that study, and 2 observational studies. It is important to note, however, there's a large body of evidence that is consistent with our finding of no increased risk of heart attack associated with testosterone use, both before these 2 studies in the last 50 years as well as subsequent to these 2 studies, as was this study here. The analysis revealed that testosterone therapy was not associated with any increased risk of heart attacks. Further, testosterone users with a higher probability of cardiovascular disease, i.e. risk factors, had a lower risk of heart attacks in comparison with equivalent patients that did not take the testosterone. So in this study, when you want to increase your risk of heart attacks, don't take the testosterone. When you want to protect against it, then take it. And, of course, the comments from the authors, this is an exceptionally well-done study containing rigorous analyses of a large number of patients. Said Dr. Baillardian, we believe that in our study, placed alongside existing studies that have already been done in the last 50 years, provides substantial evidence that testosterone therapy does not increase the risk of heart attack among older men. So now let me sort of talk about a couple of the cases that I've looked at recently. Both of these cases have been dropped. The first case, when I presented all of these other studies, the cardiovascular expert that they got testified in his deposition that he knew of only 2 studies that were harmful, and he did not know of any prior studies to show any benefit. Well, I went through and I showed him all the studies that I'm going to show you, and basically they were sort of defenseless. They didn't want to go up against me. They didn't want to go up against the studies. They didn't want to go up against my credibility versus theirs, and they had no experience whatsoever, and they eventually dropped the case. Second case was the same way. They tried to show that testosterone causes polycythemia, and we didn't address that. Testosterone causes an increase in estrogen, and that causes heart attacks, and that the doctor did not address that. And we basically blew them out of the water with both of those. And we showed significant data showing all of these other studies that showed benefit. Their claim was that the patient should not have been put on testosterone because they didn't qualify for it based on numbers. And we basically shot down that also, showing that numbers really have nothing to do other than the most recent AACE guidelines, which are trying to restrict therapy. But all the past studies in the last 50 years didn't look at numbers. They looked at symptomatic improvement, and they also diagnosed hypogonadism by looking at symptoms as opposed to restricting it based on a number. So we were able to get through that and explain to the cardiologist that he basically did not have any understanding of what all the prior studies showed, and where he was going was basically a dead-end street. They wanted us to settle. We didn't settle, and then they eventually dropped the case. So anyway, showing all of this data in these studies I was able to show that all of these other experts basically had no clue or understanding as to what the majority of the medical literature shows. This is from Consulta magazine, an article by Morgentaler, thank God for him, who has been very instrumental in helping to defend the use of testosterone. He recently had this multi-country meeting, I think it was over in the Czech Republic, and that's not yet to be published yet, but it was a world's leaders in testosterone therapy coming together to come out with a position statement on the fact that testosterone was not harmful at all and certainly beneficial for everyone's health, and that we shouldn't be restricting the use of testosterone. Anyway, in this study here, the lead author, Dr. Morgentaler, Dr. Morgentaler, Director of Men's Health in Boston, I'm sure everyone knows Dr. Morgentaler, he and his colleagues identified just 4 scientific journal articles published since 1940 that suggested a higher cardiovascular risk in using testosterone. At least 2 of those articles had serious methodological limitations, shall we say flaws. And of course, there was one placebo-controlled trial, which is the TOM study, that had, I think, 2 major events, which was a heart attack, a lot of soft events, which is what we'll cover. And it was the soft events that they included in this study that made the study so very flawed. And there was, of course, a meta-analysis that included questionable studies. They only picked 1 or 2 studies that may have shown some possible cardiovascular risk, and they ignored the plethora of data out there showing tremendous benefit. This research, along with other studies, actually demonstrates that men with low levels of testosterone who did not receive testosterone replacement therapy died at double the rate of men who did not receive testosterone, or who did receive testosterone. So if you want to live longer, happier, and healthier, then you should be on testosterone. If you want to die sooner, then go ahead and not take it. Yeah, but my doctor says, well, your doctor doesn't understand all the world's literature. Morgentaler and his colleagues note that a small number of randomized controlled studies have shown men with heart disease functioning much better when they received the testosterone and had much less morbidity and mortality as a result. In conclusion, we found no compelling scientific evidence to support the recent allegations of increased cardiovascular risk with testosterone therapy, says Morgentaler. On the contrary, a rich literature dating back more than 70 years strongly suggests that testosterone therapy has many cardiovascular protective benefits. Unfortunately, most of the doctors don't know that, and of course, attorneys are sort of looking the other way. What this means in the meantime is that primary care practitioners should not be discouraged from treating men with testosterone deficiency, also called hypogonadism, if they feel that it's clinically indicated, says Morgentaler. Treatment clearly provides important benefits for many affected men with symptoms of sexual dysfunction, decreased libido, fatigue, etc. So this is the first of many to come that will review all of the literature that shows protective effects. This is a release summary from the American Association of Clinical Endocrinologists, and they released a position statement in spite of the recent FDA warnings, and they released a position statement based on their review. The American Association of Clinical Endocrinologists responds to reports of associating testosterone replacement therapy with increased cardiovascular risk. Citing the lack of compelling evidence connecting testosterone replacement therapy with cardiovascular events such as heart attack and stroke, physicians representing the AACE today issued a position statement questioning the claims that testosterone replacement therapy increases the risk of cardiovascular disease. While several recent published studies support the association of low testosterone concentrations with cardiovascular problems, especially in older men, AACE position statement notes that low testosterone is often a marker of cardiovascular illness, not a causal factor. Additionally, the AACE position statement highlights the significant benefits of HRT in men with cardiovascular risk factors. Testosterone administration results in less fat, increase in muscle mass, decrease in insulin resistance, reversal of metabolic syndrome. So there's a multitude of studies showing both beneficial effects as far as the risk factors, but ultimately you have to prove it with outcome studies. You can surmise it all day long, but eventually you have to prove it with outcome studies. This is an interesting position statement from the European Medicines Agency, which is similar to our FDA. Our FDA, because they are sort of obliged to let the public know if there's any evidence or if there's any suggestion that there may be a risk, that they have to let people know. And that's why the FDA stepped up and said, well, there's these 2 studies. We may not agree with them, but we have to let everyone know. And as a result, they put out precautionary statements concerning the use of testosterone. Well, the EMA probably did just the opposite. The EMA, which is like the European FDA, finds little evidence that testosterone ups the cardiovascular risk in men. In fact, there is no consistent evidence that the use of testosterone in men increases the risk of cardiovascular problems, according to this new review by the European Medicines Agency. So they seem to see through it, but the FDA still is obliged to explain it. The EMA launched this review regarding cardiovascular risk for testosterone medications in April, following a similar announcement by the FDA. But the committee there has determined that the benefits of testosterone continue to outweigh any risk whatsoever. In the United States, the FDA advisory panel voted nearly unanimously last month to change the labeling for testosterone products in the intent of the aim of tamping down on the current widespread use of such agents for age-related hypogonadism or anti-aging. So this last paragraph is an extremely important paragraph to understand the current state of affairs. For the last 50 years, we've been able to prescribe, use testosterone to help improve quality of life and help decrease cardiovascular diseases, as well as the many risk factors associated with it. But because of that article that appeared in Time magazine, where testosterone has been used for anti-aging, and there's anti-aging clinics everywhere, and men are going into these men caves and getting their testosterone shots, that they needed to sort of put a crimp into that. Well, the FDA then came out and discouraged doctors from prescribing it, and they encouraged the AACE to come up with their new, most recent guidelines that you should not treat any man with a total testosterone less than 300. In spite of the fact that there's a multitude of medical articles, including the articles from JCEM that say that there's no biological parameter that denotes hypogonadism, that don't use a number to denote hypogonadism, because symptoms can occur in patients with very high testosterone levels and they respond quite well to the therapy. But because of this desire of the FDA to suppress prescribing of testosterone, AACE came out with these statements, and in the most recent literature in the last 2 years and all these articles that were published, we're now starting to see articles that say that they did not treat any man unless their total testosterone level was less than 300. I completely disagree with that. Morgentaler disagrees with it. Many other experts also disagree with it, but you have to understand where it came from. At the release of this information, many members of AAMG were very, very upset with this notification that you shouldn't treat anyone unless their testosterone level is below 300, and on 2 separate occasions, and only taken in the morning when the level is the highest and not in the afternoon when it's the lowest, because if you took it in the afternoon and it's low, then they would qualify for treatment. And since we're trying to eliminate men from getting it, then we only want to test it first thing in the morning when it's the highest, so we can eliminate and prevent other men from getting it that would benefit from it, if you understand what I just explained. And as a result of that, they say we shouldn't use it. Well, that's not supported by any medical literature, but that's what we're tending to see in the most recent studies, which is of concern for many physicians because of those guidelines. And I think that the guidelines by AACE, because of the FDA, has sort of hindered many physicians, because now they're afraid of doing that, or they're less likely to do it if the level is greater than 300, and as a result, men are going to suffer the consequences of not taking it. In the 2 cases that I talked about earlier, the patients did not have testosterone levels less than 300, and as a result, the experts said that they did not qualify for therapy. And my rebuttal to that was, if they had fatigue, low libido, high cholesterol, increased body fat, and a multitude of symptoms associated with hypogonadism, how would you then treat those symptoms? Well, they said that they wouldn't, because they don't qualify for treatment based on those numbers. And I said, why would you be so cruel to restrict therapy based on a number that somebody just picked out of the air, and that the FDA says to use in order to try to restrict therapy. Well, that's what they've done, and unfortunately, there's now a backlash against that. And what the FDA did and what AACE did was very unfortunate, because now we're having to defend the use of testosterone in men whose levels are greater than 300 but still have all those signs and symptoms of low testosterone hypogonadism, but we restrict them from getting that based on a preconceived number that somebody pulled out of the air. There's two nice review articles from JCEM years ago, just after testosterone was FDA approved for use. The articles basically said that the FDA approved testosterone for treating symptoms of hypogonadism. They didn't approve it for treating a number. They didn't approve it for improving numbers. They approved it for treating symptoms, and that the goal of the use of testosterone should be to improve quality of life by improving symptoms that can be associated with low testosterone. Well, some other groups have now taken that further and have decided that we shouldn't use a number to define hypogonadism, but what we should do is define symptoms, and that the symptoms denote hypogonadism, because no number has been shown to be diagnostic, and as a result, we shouldn't restrict therapy based on numbers. But nevertheless, AACE and FDA have done this, and now we sort of have to deal with it, which is very unfortunate. Anyway, moving on. In this study here, another study finds that testosterone replacement does not increase cardiovascular risk. This was the first of two studies that was done by this Heart Institute in Utah. In this first study, researchers found that men who received testosterone supplementation to achieve normal or high testosterone levels, with a key emphasis on the word high, had reduced overall rates of major adverse cardiac events, meaning MI, at 1 and 3 years after their initial low levels of testosterone were measured and treated. The lower the rate of cardiac events included a reduction in the adjusted risk of death, as well as the reduction in MIs. This is an extremely important study, an extremely important paragraph to understand. But going back to that first sentence, researchers found that men who received testosterone to achieve high testosterone levels. There's a recent study in JAMA that was published that showed that testosterone doesn't work. And what they did was they took men who had levels of testosterone less than 300, they treated them with a transdermal commercially available gel and got their levels up to 400. When they got their levels up to a whopping 400 and they looked at libido and sexual function, they said that it did not improve. Therefore, we shouldn't be using testosterone because it didn't work. For those of you that have taken the courses, you know my example of, well, we took men with kidney stones and we gave them 1 milligram of morphine and it didn't work, so therefore we proved that morphine didn't work and we shouldn't use morphine. Yeah, but in every study when you use 10 milligrams it works fine. Yeah, but in another study with 1 milligram it didn't, so therefore you shouldn't use it. Well, now you sort of see where the agenda is going, and there's going to be probably a long list of studies that are going to show that testosterone doesn't work. Well, of course it doesn't work because they didn't get their testosterone level up high enough. If you're going to get levels up high enough to help improve libido sexual function, your level is probably going to have to be a total testosterone of at least 600 to 800. A level of 400 is absolutely worthless. But anyway, now you can see this pushback by AACE and other groups that are trying to, unfortunately, denigrate the use of testosterone. The new findings that testosterone therapy is generally safe and does not increase the risk of major cardiac events for men with low testosterone levels provides assurance to physicians across the country and should provide assurance to those that are having to defend their position of using it. When it's needed with less concern about its effect on the patient's heart health, researchers said. Testosterone therapy has become a very popular treatment in the United States in recent years, says Dr. Jeffrey Anderson, a cardiologist at Intermountain Medical Center Heart Institute. With this study, we're getting closer to defining the true associations between testosterone treatment and cardiovascular risk or benefits. Well, that's the first of many studies that I'm going to show and that are of great benefit. This is the second study done by the same group, but at a later time. A new study of generally healthy men who use testosterone replacement to normalize testosterone levels was found that taking testosterone supplementation did not increase the risk of experiencing a heart attack or a stroke. Researchers found that generally healthy men who received testosterone supplementation to achieve normal levels did not increase the risk of strokes or heart attacks. So now we see studies on both healthy men as well as studies in men that were ill and had significant cardiovascular risk. And we did not see any increased risk in either of those groups. We only saw a benefit. Our research examined the potential cardiovascular risk associated with generally healthy men who used testosterone supplementation to normalize their levels and found no increase in those risks. I have found that these cardiologists, that these attorneys are using continue to harp on the fact that testosterone was not indicated because the levels were not low enough. And as a result, did they then increase the risk? Well, who cares what the level was? Giving them testosterone did not increase the risk. Notice that they said testosterone was given to healthy men. They didn't look at men that had levels less than 300. They took men that were normal, that were healthy, and gave them testosterone and then observed to see what happened. In fact, testosterone therapy in this population was shown to reduce the risk of heart attack, stroke, and death when compared to those men who were not taking testosterone supplementation. When you want to increase the risk of dying, do not take the testosterone. When you want to protect against the risk of dying, heart attacks and strokes, then you should prescribe the testosterone. Yeah, but it was not indicated because the level wasn't low enough. And my rebuttal was, what about the number caused you to not think that the man should be protected against heart attacks, strokes, and death? What was it about that number? Why would you not want to protect that person against strokes, heart attacks, and death? Well, because they didn't qualify based on a number? What man would not qualify for protection against heart attack, stroke, and death? Please explain that to me. They couldn't, which was really unfortunate for them because they lost. This particular study provides assurance to physicians, again, and patients using testosterone replacement therapy in a generally healthy population of men over age 50 that normalize their levels doesn't increase the patient's risk of heart attack or stroke and actually shows a reduction in those risks. It's interesting that they use the term normalize. They stayed away from looking at numbers or levels because many of these patients that are taking the injectable testosterone have levels 2,000 to 3,000. And of course, if you looked at those numbers, you would be very uncomfortable with the fact that the number is too high and somebody's going to criticize a number. So what the most recent studies have done is they've looked at normalizing. They won't give the numbers. All that they say is that we normalized it, somewhere in the normal range. Well, the normal range is quite large. So anywhere within that normal range is defined as normalizing, and that's exactly what I do. This is an article from Mayo Clinic Proceedings, again, showing benefit. In this study here, this is Morgenthaler's study. 4 articles were identified that suggested an increased risk of cardiovascular risk with prescriptions. And I want to go over this limitation again. One placebo-controlled trial, which was the TOM trial, that had a few major adverse cardiac events. The problem with that study was this. The TOM study looked at hard and soft events. A hard event is a stroke or heart attack. A soft event is self-reported symptoms, and the most common self-reported symptom was edema. Well, testosterone increases edema, and if the patient reported an increased edema, it was listed as a cardiac event, which is why this study showed an increase in adverse cardiac events. In addition, if they had an echocardiogram or if they had a stress test that was abnormal, it was listed as a cardiovascular event. Well, they could have had that abnormal plaque in their hearts for 20 years, and now they did a stress test and saw it, and that was included as the hard event. I mean, excuse me, as a soft event, but as a cardiac event. So the TOM study, which was not really powered to look at cardiac events, was listed as one that showed an increase in cardiac events, and as a result was stopped. But most of the cardiac events that they listed were soft events like self-reported edema. If they had a plane flight and they got edema on the plane flight and reported it as edema, it was a cardiac event. Aha, see, testosterone increases the risk of cardiac events. Terrible study for looking at cardiac events, but it's out there in the literature as one of those studies to show harm, whereas in reality, it really shouldn't be listed as an article that shows harm. On the other hand, in contrast, several dozen studies have showed cardiovascular protective effects, beneficial effects of normalizing testosterone on cardiovascular risk and mortality. Mortality and incident coronary artery disease are inversely related to testosterone levels. We've seen that in every study, as well as in the severity of the coronary artery disease. The lower the level, the worse the disease. The higher the level, the more protective. Testosterone therapy is associated with a reduced incidence of obesity, fat mass, and waist circumference. And again, I criticize these cardiologists for saying these patients did not qualify. And all of these patients have obesity. They all have increased fat mass. And my response back to them was, please explain to me how the patient did not qualify for a decrease in obesity and fat mass. Explain to me why you would not want the patient to decrease fat mass and lose visceral fat. They couldn't answer it, other than they didn't qualify for it. Well, obviously, they sort of shot themselves in the foot when they said they didn't qualify for it. Is increased fat mass a risk for cardiovascular disease? Well, yeah, of course it is. Well, then why is it that you don't want to use testosterone to help improve that? Because they don't qualify for it. Well, they lost out. Mortality was reduced with testosterone therapy in 2 retrospective studies. What about these other studies? Don't you understand, Dr. Cardiologist? All of these other studies show reduced coronary events and a decrease in mortality. How is it that the patient did not qualify for a decrease in mortality based on these other studies? They can't answer it. Several randomized controlled trials in men with coronary artery disease or heart failure reported improved function in those that received testosterone. And the largest meta-analysis to date, revealed no increased cardiovascular risk in men who received testosterone, and they had a reduced cardiovascular risk amongst men with metabolic disease. A recent study just came out this week showing the same thing. In summary, there's no convincing evidence that increased cardiovascular risk with testosterone therapy, period. On the contrary, there appears to be a strong beneficial relationship between normalizing testosterone and improving cardiovascular health that has not yet been widely appreciated, thanks to the media and thanks to the negative hype. But Morgentaler described it perfectly. I've basically copied this, presented it in court, and have won because the cardiologist cannot defend any of that. This is another study. This is an AACE annual meeting press release. The benefits of testosterone replacement therapy to treat low testosterone in both men and women substantially outweigh any risk, according to a panel of researchers from the American Association of Clinical Endocrinology. And when I ask the cardiologist about this, I say, are you an endocrinologist? No. What comment would you have that a panel of endocrinologists that are experts come out and state that there's beneficial effects of using testosterone and there's no harmful effects? How can you defend that? Well, these 2 studies, yes, those are 2 flawed studies, and unfortunately the cardiologists do not realize they're flawed. Anyway, the panel comments were in response to the FDA's safety alert cautioning that the benefits and safety of testosterone medications prescribed for age-related low testosterone levels have not been established. The comments, unfortunately, are aligned with the soon-to-be-published AAC reproductive statement on the association of testosterone and cardiac events, which they would have studied this, would publish this earlier as opposed to later. Anyway, there's new comments that will be published showing there's no compelling evidence that testosterone therapy either increases or decreases cardiovascular risk. I disagree with that. There's quite a few studies showing decrease in cardiovascular events, but again, a purist will criticize and say, well, that study was not powered. Well, how can you say that dozens and dozens of these studies are not powered when you will say that 2 extremely flawed studies show an increased risk? It just does not make sense. It's really, really very unfortunate that they do this. Anyway, nevertheless, they've come out with a statement saying that many cardiovascular risk factors can be improved with testosterone by decreasing fat mass, improving muscle mass, and decreasing insulin resistance. So far the EMA has come out with statements that are positive. AACE has come out with statements that are positive. Unfortunately, AACE has come out with statements that you shouldn't treat any man unless their testosterone total is under 300, which I completely disagree with. So this is a very long, labor-intensive article, but I used it as the first article to review the use of testosterone because there's so many important articles in this. Epidemiologic studies have found that men with low testosterone are at an increased risk of mortality than those men with higher levels. When I asked the cardiologists about that, they have no comment. Cardiovascular disease accounts for the greater proportion of deaths in those with low testosterone, and it is due to an increased risk of obesity, metabolic syndrome, diabetes, inflammatory disorders that are all increased with testosterone deficiency. There's convincing evidence that low testosterone is a biomarker for disease severity and mortality. 2 retrospective studies of men diagnosed with hypogonadism with or without type 2 diabetes have reported significantly improved survival. And why is it that you don't want your patient to have improved survival? Why do you think that they don't qualify for improved survival? They have no comment. The prevalence of hypogonadism in male populations is not known with certainty due to part in lack of a consensus on the threshold that should be used to define testosterone deficiency. And that's a real problem. And in my book, in my opinion, I don't need to wait for a level to be low. As far as I'm concerned, if your level is not optimal, which is where everyone tends to find benefit, then it really doesn't make any difference what your baseline level is. And I don't restrict therapy based on a baseline level that does not meet someone's criteria. I base my therapy on the level's not optimal, they're not deriving benefit from it. Hypogonadism is defined as a clinical syndrome which compromises both symptoms and biochemical evidence of testosterone deficiency. Sorry, comprises. Clinical guidelines have provided some direction for cutoff levels of testosterone, but these also differ. Everyone has a different opinion as where your level should be before you treat somebody. But nobody has any consensus on where your level should be when you treat somebody for maximum benefit. But the studies overwhelmingly show the higher the level, the better the effect. Differences in the measurement of testosterone between assays and laboratories also lead to problems interpreting these thresholds, which is again why there's so much controversy with using levels. We really shouldn't be using levels to define when somebody needs to have therapy. It should be based on symptoms. The majority of the longitudinal, mainly community-based population studies have reported significant associations between all-cause mortality and low testosterone levels. A recent systematic review and meta-analysis of 12 community-based studies concluded that low testosterone levels at baseline were associated with an increased risk of both all-cause as well as cardiovascular mortality. All-cause meaning cancer, diabetes, osteoporosis-related fractures, and cardiovascular mortality. There's a multitude of studies which I won't go into, but it's there for your reference that show beneficial effects in reducing all-cause mortality. And it's interesting that when I present all of these studies to the cardiologists, they sort of don't know what to say. They're not aware that all of these studies exist. More studies, more studies. I won't go through each one, but pretty much they all show the same thing. Men with low or equivocal testosterone levels had higher mortality than men with normal levels. The risk of death was 44% higher in the lowest quartile of testosterone in relationship to the highest. Testosterone was inversely related to all-cause mortality, cardiovascular disease, as well as cancer in these studies. All these studies show the same thing: increase all-cause mortality when your levels are low. Same thing, independent risk. What is it that we don't understand about all these different studies? There's a decreased 5-year risk of major cardiovascular events and mortality with testosterone use. Low testosterone, adverse effect on mortality, obesity, dyslipidemia, insulin resistance, endothelial dysfunction, and inflammation. If cardiovascular disease is such an inflammatory disease and testosterone lowers inflammation and all the studies show that, then why would the cardiologist not want to use it? Well, because they didn't qualify for it. When they kept saying that they didn't qualify for it, eventually they realized that that was the only response or rebuttal that they had, and they lost on that. Testosterone helps improve patients with diabetes. Testosterone helps improve patients not get cancer. It helps improve respiratory disease. It helps improve patients that have renal disease. There's a multitude of different problems that we have that testosterone improves. Looking more specifically, these are two pretty powerful studies looking at mortality. Two studies have now been published examining the effect of testosterone replacement in men. One was a Seattle study. It's a retrospective study, but nevertheless, they found that testosterone replacement therapy significantly reduces mortality over 40 months. Testosterone-associated decreased risk of death. In the Barnsley study, they showed the same thing. Testosterone replacement therapy decreases all-cause mortality and has significant survival benefits. And of course, when I asked the cardiologist, why would you want to restrict that for your patient, and what is it that makes your patient not qualify for survival benefits? Please explain that. All they could come up with was they don't qualify. And I said, how could any man not qualify to have improved survival? The reasoning is very, very flawed, as you could very well see, based on all the literature that I produced. The mechanism by which testosterone improves mortality can be related to benefits on cardiovascular risk factors, decreasing fat content, decreasing cholesterol, decreasing systemic inflammation, and beneficial effects on the immune system. When you look at a bunch of different meta-analysis, there's quite a few different meta-analyses that are now out there. They have not found any adverse effect of testosterone replacement therapy showing an increased risk of cardiovascular events or mortality, except in the TOM trial. But as I told you before, this was a study that had some significant flaws. Not that the study itself was bad, but the conclusion of the study was bad because the study was not powered to look at cardiovascular events, and the primary recorded range of heterogeneous cardiovascular-related events included syncope, I passed out, edema, I've got edema. I had an abnormal stress test. They were then listed as cardiovascular events, which severely skewed the data, showing that patients that took testosterone had an increased risk. Aside from this TOM trial, which again is flawed, no other major randomized, double-blind, placebo-controlled trial has showed any adverse cardiovascular outcome with testosterone therapy. When I asked the cardiologist to read this statement, and I asked their comment, they say they have no comment. When I asked them, do you know of any other studies that show that testosterone is a benefit and that using testosterone does not cause any increased mortality? They say no, that they don't know of any. And I say, well, read this here and understand what it says. There's plenty of studies. This was a similar study that probably everyone already knows about from the VA study that I won't go over. But this study was heavily flawed for several different reasons, and this is important to understand to be able to discuss it with the cardiologist. There's a couple flaws up here which I won't talk about, but thirdly, the raw data showed less cardiac events for each endpoint in the testosterone-treated group. Yes, we all have to read that a couple times in order to be able to understand what that says. The patients in the testosterone-treated group had less events than those in the placebo group. Then why did the study show the opposite? It was a statistical analysis using 50 variables using the Kaiser-Fleischer model that suggested the opposite result. Fourthly, 1,100 studies that had myocardial infarction or stroke that were given testosterone after these events were excluded from the analysis. And if these had been included, then a beneficial effect of testosterone would have been indicated. So the study would have completely different results had they not made these flaws. But unfortunately, they made the flaws and they got a different result. So a safe conclusion cannot therefore be made without knowing the correct diagnosis. And some patients not continued therapy, and those on testosterone having suboptimal testosterone levels even before the statistical methods were challenged. You can see that there's a multitude of flaws in this study, but everyone wants to hang their hat on that one study that has since undergone 2 major corrections. The second study, of course, was in patients that received prescriptions, and there was an increase in risk of non-fatal MI 3 months after the prescription was issued. We don't know what those levels were. We don't even know if the patients took the testosterone or not. And there's many weaknesses in this study here with no data on whether or not hypogonadism had even been diagnosed or if the testosterone levels were measured. and there's no evidence of compliance because they didn't monitor therapy and they don't even know if the patients took it or not. So again, major flaws to these two studies, and when I ask the cardiologist, do you know of any flaws, they say no. Patients with known cardiovascular disease would logically be more expected to have an increased risk of events. However, several trials of testosterone between 3 and 12 months in men with either proven coronary artery disease or moderate cardiac failure have not reported any adverse cardiovascular events except in the placebo group. In summary, all of these studies found benefits and no harm. Then why would you not want to look at the studies that showed all the benefit? Well, because they don't know about those studies. It's really a shame. Longitudinal studies have shown that testosterone increases mortality. Furthermore, differences between androgen receptor sensitivity down here in these polymorphisms also give rise to this symptom-specific threshold. And that's an issue because many patients will be denied therapy even though they have symptoms. And there's a multitude of reasons that they have symptoms, and we shouldn't really deny it based purely on a blood test, which should be really thrown out. In summary, testosterone deficiency may have an adverse effect on general health. Testosterone deficiency associated with a poor quality of life, reduced physical strength and muscle bulk, fatigue, depression, changes in motivation, poor concentration, depression, impairment of the immune system. I asked the cardiologist what treatment they would use for these things, and they say they have no comment. Evidence from two, albeit mainly retrospective studies, reported near identical results that testosterone therapy improves survivals in comparison with those that are untreated. Anyway, this is a nice review of a multitude of different studies, pretty much showing all studies except for those two show beneficial effects. This is a nice study that looks at hypogonadism, however you define that, to determine the prevalence of thrombotic events and all-cause mortality in men over age 65 with hypogonadism treated with testosterone therapy. We evaluated all-cause mortality, prevalence of MI, not soft but hard end, transient ischemic attack, CVAs, and deep venous thrombosis. There was an increased all-cause mortality in hypogonadal men not treated with testosterone compared to men treated with testosterone. There was no difference in prevalence of MI, stroke, TIA, PE, DVTs in patients treated with testosterone and patients not treated with testosterone. So a very, very, very nice, much larger study showing that what the cardiologists are claiming is not true when you look at a multitude of other studies. Low testosterone is a measure of poor health with an increase in cardiovascular morbidity and mortality, and the goal of testosterone supplementation is to ameliorate hypogonadal symptoms and improve quality of life with minimal adverse effects. I asked the cardiologist, how did these patients not qualify for an improved quality of life? And they basically said, no comment. Despite several studies demonstrating the beneficial effects of testosterone in cardiovascular health, two epidemiologic studies from the past year spawned debate. We've already gone through those studies. In this study here, they looked at 217 men. Some got testosterone injections, some got the gel, and some got the pellets. And they looked at what the results were in this study. And the results showed that there was beneficial effects. The use of testosterone therapy in elderly men is reasonable given that hypogonadism is an independent risk factor for cardiovascular disease and all-cause mortality. You didn't want to use the testosterone in these patients because you did not want to reduce all-cause mortality, doctor? No comment. They didn't qualify for it. Ridiculous. Furthermore, improvements in risk factors for cardiovascular disease, such as body weight, body fat, hemoglobin A1C that's lowered, and total cholesterol that improves, can contribute to the decrease in thrombotic events. Some of the weaknesses of the larger studies include lack of adequate control groups, lack of availability of testosterone levels before and after therapy, short-term follow-up. These studies that we've already talked about have significant flaws that has been mentioned in all of these subsequent studies. Nevertheless, everyone wants to hang their hat on those studies, and really they should not. And I've got the cardiologist finally to say no comment multiple times. In our small retrospective cohort study, testosterone supplementation does not increase the risk of thrombotic events in blood vessels of the heart, brain, or legs or lungs. Consistent with the majority of studies in the literature, there was an increased all-cause mortality in hypogonadal men not treated with testosterone. Explain that to me, Dr. Cardiologist. If the lower the levels associated with increased risk and higher levels and treated levels are protective, please explain to me how the patients did not qualify for this. No comment. No adverse risk, period. Another study showing safety of what we do and why we do what we do. Lastly, this is the last study that I think is extremely important. It goes through a multitude of different other studies. It makes some comments on those, but this study is important from the standpoint of they normalized testosterone. They didn't define what normal was. They normalized it, anywhere to the upper end of the range from a level of 300 to 1,200. The higher the level, the better the effect. So another study showing benefits, lack of harm, but the importance is optimizing levels. There's a significant uncertainty, not in my mind, regarding the effect of testosterone replacement therapy on cardiovascular outcomes, including MI and stroke. The aim of this study is to examine the relationship of all-cause mortality, MI, and stroke, and see what we can come up with. The conclusion of this study was, in this large observational cohort with an extended follow-up, normalization of testosterone levels with therapy is associated with a significant all-cause reduction in mortality, MI, and stroke. Please explain to me how any man does not qualify for decreased MI and stroke. I don't get it. Explain that to me. No comment. Professional guidelines recommend testosterone replacement in patients with signs and symptoms of hypogonadism. Of course, they say also evidence of low testosterone levels, but we don't know how to define low testosterone levels. It's not really defined in any literature, just personal opinions of what low level is. Recent retrospective studies, multiple meta-analysis, and a few prospective studies have presented conflicting results, and as a result, it leads to tremendous confusion for practitioners, as well as uncertainty. Observational studies suggest that low testosterone levels increase risk. Two separate retrospective studies in the VA system using two different databases reporting opposite effects. One study by Vigen et al., harmful effects, the other study by Shores, beneficial effects. So this is the confusion in these studies. They are observational. They're pretty much very similar by design. So what they did was they conducted a large retrospective study of long-term follow-up to address this knowledge gap. The objective of this study was to examine the association between testosterone use and normalization of total testosterone, which is what they did not do in these other studies, and then look at all-cause mortality and cardiovascular events. So great design. Let's see what they showed. Data from position statements of the Endocrine Society and several other sources suggest that testosterone levels can vary significantly between laboratories, even when they use the same identical laboratory kits. Moreover, because the assay ambiguities and biological variations, no single cutoff of testosterone value can clearly distinguish between hypogonadism and eugonadism. However, I've gone back and I've looked at all the studies where they treated men with eugonadism, and they found the same thing. Beneficial cardiovascular protection, less MI and stroke. I don't care if it's hypogonadism, I don't care if it's eugonadism, I care it's not optimal. There's also lack of standardization when it comes to testosterone levels and other tests using these different stoichiometric measurements. So how you define it based on what tests you use is very, very arbitrary, but everyone wants to hang their hat on it, and I strongly encourage that we don't hang our hat on it. This is the data which I won't go through, and I will let you look at the data if you really want to look at. But more importantly, the discussion. In this study of men with low testosterone levels without prior MI or stroke, normalization of testosterone levels using testosterone therapy associated with lower risk of all-cause mortality, fewer MIs, and fewer strokes. Normalization, optimizing, that's the key. That's what people tend to not look at in these studies, which is very unfortunate. In retrospective studies, they describe the largest cohort of such patients and the longest follow-up to date in this study. It was the first study to demonstrate that significant benefits observed only if the dose is adequate to normalize the testosterone levels. Patients who failed to achieve the therapeutic range after therapy did not see any reduction in MI or stroke and had a significant less benefit on mortality. Optimizing it, the higher the level, the better. Show me a study where high levels are harmful. Can't find it. Show me studies to show that low levels are not protective. Well, there's lots of them. We attempted to overcome the potential limitations of inadequate treatment by using follow-up testosterone levels as a marker of adequacy of dosing and compliance, which those two prior observational studies did not. We don't know what the levels were, and we have no idea what the follow-up was. Several recent retrospective studies have investigated the association of testosterone with outcomes. These are what we already talked about before, showing an increased risk. What they tried to do in this study was to avoid the flaws of those other studies. Since I'm lacking time, I'm going to move forward to the summary. I won't review Finkel's study showing how flawed it was. I won't look at this study which showed benefit, which was a VA study also. Okay, summary. Our data found normalization of testosterone after therapy was beneficial against cardiovascular disease risk and all-cause mortality. It can be postulated that the beneficial effect of normal testosterone on adipose tissue, insulin sensitivities, and lipids, or by its anti-inflammatory, anticoagulant properties, as reported by other investigators, have contributed to our findings. This is sort of interesting here as a summary, which is what I was hoping that they would say. Finally, off-label use of testosterone remains a concern. Well, for use in bodybuilders and young people, yeah, that's a concern, but I don't know what they mean by off-label use. Because they don't have a level less than 300? Well, that's a concern to me that they're restricting patients from getting it that would otherwise benefit from it. Recent FDA analysis suggests that currently only half of the men on testosterone have been diagnosed with hypogonadism. Do you know any man over age 40 that does not have some symptom of hypogonadism? Furthermore, 25% of users did not have the testosterone concentration tested prior towards initiating therapy. So you would have used that testosterone test to restrict therapy in somebody that had symptoms, it would benefit from it? I disagree with that. However, two very recent meta-analyses suggested a lack of convincing evidence posed by testosterone therapy, period. So anyway, I hope that was fun. I hope that was giving you enough support for why we do what we do and to continue to do why we do what we do. So let me do some questions. Richard Del Balso says, patient age 66 never had injury that didn't heal before 3 months ago, retrocalcaneal bursitis from playing tennis, treatment conservatively ever since, but absolutely no improvement. He doesn't want to have surgery. Could low testosterone impair the rate of musculoskeletal healing? I'm sort of surprised you'd ask the question, but the answer is yes, obviously it will impair healing. That's what it is. It's a healing hormone. Anyone with any sort of problems with muscle, ligaments, joints, tendons, bones will improve on testosterone. The chronic pain, discomfort that we get when we exercise can be eliminated or improved significantly, as well as the healing. For those of you that are on testosterone, I'm sure that you probably look at this question and go, why would anyone ask that question based on all the studies to show improvement in symptomatology? So yes, this patient would definitely benefit from it. In my sarcastic overtone, Many doctors would probably not treat this guy if he had a testosterone level greater than 300. No, you don't qualify. You don't qualify for impaired healing? How is it that makes you think that you do not qualify for it based on a preconceived number that's trying to restrict men like this from getting the testosterone? I think that's just preposterous. Next question, would you review the optimal total and free testosterone for men and women based on the lab which performs them, specifically LabCorp and Quest? You sort of have to go to the courses to really understand this answer, because I spent about an hour and explain why I do what I do. But if you're going to look at, and this is not what I do, but if you want to look at optimal levels for Quest and LabCorp based on their numbers in their lab, LabCorp, the optimal is around 1,200. I think Quest, the optimal is 1,100 to 1,200, depending on which Quest lab machine is used. Their free testosterone will vary depending on what test that you use. The old free testosterone test for LabCorp has gone by the wayside. Now there's a couple of other tests that you can use. They all have different ranges and different values. If I give you one, it won't make sense. So if you focus on optimizing the total, I think that's pretty much good to go. I use equilibrium test, and I shoot for levels up around 40 for LabCorp. For Quest, the upper end of free testosterone is around 210. For women, it's different. For optimization based on their lab test, Quest and LabCorp use an optimal level of around 80. That's not the one that I use based on looking at the scientific research showing that optimal levels in order to help improve symptoms are much higher than this. But if you want laboratory values, simply stay within the range that's stated on the lab slip. I will caution you on the range for the age will typically be printed on the lab slip. So if you're 80 years old, the range of expected is going to be printed on the lab slip. That's a range of expected for the age. That is not what is most optimal or best for the patient. It is what is expected based on age studies. I don't want to be the age. If you want to be the age, then don't take the testosterone. But optimization, as the New England Journal of Medicine states, and so does JCEM, is shooting for the upper end of the range of a young adult's values, and they will differ depending on the test and which lab that you use. The endocrinologist also recommended phlebotomy if hematocrit is greater than 55. They all will do that. I will, in webinar number 3, address those issues. I had a patient with a PE, and he thought it was due to testosterone treatment. How can I respond to that? I just say there's no study that shows erythrocytosis causes an increase in PE and DVT. You are absolutely correct. In fact, the majority of the studies, and there's one recent one which was a nice meta-analysis, again, I'll do that in the 3rd webinar, shows that erythrocytosis does not increase the risk of DVT or PE. But everyone thinks that erythrocytosis is polycythemia, and polycythemia increase white cells, red cells, and platelets, and it's increase in platelets that causes the DVT, PE. But many people will associate or extrapolate erythrocytosis to polycythemia, and it is not. In summary, everyone that lives at altitude has erythrocytosis, no increased risk of strokes, heart attacks. If there was, we tell everyone that lives at altitude to go down to sea level. 2, patients with COPD have erythrocytosis. We don't phlebotomize them either, no increased risk of strokes or DVT with that. But we all know that people with high red blood cell counts have increased risk of strokes and heart attacks. That's due to the increased platelets with polycythemia, not with physiologic erythrocytosis. If you look at all of the data, except for the 2 flawed studies, if you look at all the data in the last 50 years on the use of testosterone, increasing erythrocytosis, not one study shows an increase in DVT, PE, MI, or stroke. Sorry. How can you respond to it? We'll take the articles that I show and give them to people and explain to them that no study shows that taking testosterone does it. We'll get into Dr. Grueck's articles where he claims that patients that have congenital thrombophilias and take testosterone have an increased risk of blood clots. We'll look at those studies, but when you look at the general population, we do not see that. I had a patient that had a blood clot that came into the ER that was 51 years of age, and I almost missed it because I didn't think it was a blood clot. It was a massive PE. He had all the signs and symptoms of something else other than a PE, and I completely missed it until I finally did a CT angio and picked it up, and I almost missed it. almost missed it. There's an article recently published that this patient came into the ER on testosterone and had a massive PE that was 51 years of age, and they blamed it on the testosterone. Well, I had one the same way that was 51. He was not on testosterone. He had the same big, massive PE. So observation does not prove causation, and observing one patient does not prove that the testosterone that he was taking caused it. However, because we all know that hormones cause blood clots, everyone thinks that it does, and I would expect the physicians, the peers, to say that, but that is not true. It does not cause it, and no study supports that. Question, sorry, there's no study that shows erythrocytosis causes PE or DVT. Yeah, I know that. Then why does everyone say that erythrocytosis needs to be treated because it causes it? In the recent AACE guidelines, it states that patients that have a hemoglobin greater than 55 need phlebotomy. The problem with that is that everyone thinks and knows that erythrocytosis causes strokes and heart attacks. And because everyone knows, you'll be hard-pressed not to treat it and to lower it by phlebotomy. So I sort of have changed my stance on it. If a PMD or someone else makes claim that you've got to lower the hemoglobin because there's a risk, then go ahead and phlebotomize, because you're not going to be able to teach or show them that it is not harmful. Hi, Dana. Wondering if you have a list of articles referenced in this webinar. Yes, you're going to get, if you contact Dana, she'll give you copies of all the articles that I showed in this webinar. What's my opinion on controlling high serum estradiol levels in men? Treat or don't treat? Everyone knows that the world is flat. For those that know and think that the world is flat, and they've known that the world is flat forever, there's no way that you can convince them that the world is not flat. We all know that high red blood cell counts also cause strokes and PEs, in spite of the evidence against it, because we're all taught and we know that high levels of red blood cells cause strokes and heart attacks. Same thing applies to estrogen. We all know that high estrogen levels increase the risk of strokes and heart attacks. I've given this lecture a couple times at AMMG, and if you want to get an earlier lecture, you can go on YouTube and look at my lecture on testosterone and polycythemia and testosterone and estrogen in men. So what study showed that high red blood cell counts cause strokes, heart attacks? None. What study showed that high estradiol levels cause strokes and heart attacks? Quite a few, but let me differentiate between the two. One study is a baseline level. The other study looks at treatment levels. If you look at baseline levels, all studies show high estradiol levels are harmful. But high estradiol levels in women are also harmful, increasing risk of strokes, heart attacks, and breast cancer, because high baseline levels are associated with increased visceral fat that increase the risk of strokes, heart attacks, and breast cancer. The same thing applies in men with high estradiol levels. In baseline levels, high estradiol levels are associated with an increased risk. That's baseline. But it always goes up when you treat. Therefore, it must be harmful. No. You're extrapolating the harm with a baseline to a treated level. You cannot use association to prove causation. High baseline estradiol associated with increased risk, but that does not prove causation. How do you then study it? You got to give it. When you give it and raise it, that's an interventional trial. There's 50 years of studies giving testosterone to men that increase estradiol levels. What study showed harm? None. What study, when we gave estrogen to men, caused or showed harm? None. Why would you give estrogen to men? Well, when they have prostate cancer. Estrogen is a great treatment for prostate cancer. That's webinar number 10. So in men, when we give them estrogen, there's a decreased incidence of strokes, heart attacks, cholesterol, dyslipidemia. If you look at the New England Journal of Medicine study 2013, they gave men testosterone and they divvied them up into two control groups. One got aromatase inhibitors and one did not. The one that got the aromatase inhibitor and blocked estrogen had a significant increase in visceral fat, subcutaneous fat, if you want to call that gynecomastia fat, you can, an increase in cholesterol, an increase in sexual dysfunction, and erectile dysfunction when you blocked estrogen. In the untreated group, when you unblock the estrogen, decrease in visceral fat, subcutaneous fat, improvement of sexual function, improvement of libido, and a decrease in erectile dysfunction. You decide where you'd like to be. Yeah, but high levels are associated with. Everyone wants to jump on this associated with, but no one can show me a randomized control trial in the last 50 years when we raised estrogen in every study that it was harmful, either causing cardiovascular disease, strokes, diabetes, or prostate cancer. There is no evidence to support that. But you'll get all of those studies in a much greater detailed lecture when I do that. So I don't control high estradiol levels, and people will say, well, you want to keep it below 70. You want to control it just a little bit. You want to increase visceral fat, heart attacks, strokes, diabetes, osteoporosis, fractures, erectile dysfunction, and sexual dysfunction a little bit? Is that what you're trying to do? It makes no sense. But everyone wants to do it because they read a baseline level is associated with, and they do not understand association versus causation or the plethora of data to show that giving testosterone and raising it is beneficial. Is it important to consider the form of administration, topical versus injectable, in achieving normalization and ability to measure those retrospective levels, as topical can potentially be overdosed if measured only in serum? I do not understand how topical can be potentially overdosed if measured only in serum. I need to see what overdose means. I've never seen anyone that's overdosed. I don't understand it. There are studies to show that if your testosterone level is too high, like 4,000 to 5,000, you can have an adverse effect on lipids. But if you use an injectable testosterone, we want to measure the levels on day 7 to 10. Why 7 to 10 and not 1 to 2? Because if you measure it on day 1 to 2, the level's 3,000 to 3,500, and everyone gets scared. If you wait for day 7 to 10 when the levels fall, then the number is much lower, and it doesn't upset anyone. So what we're going to do is artificially manipulate the day in which we test it in order to get a number that pleases everyone. Well, that's ridiculous. Yes, but that's reality. So it really doesn't make any difference. If you do not use enough of the topical testosterone gel or cream, you're not going to provide optimal cardiovascular effects. And one of the most beneficial cardiovascular effects, which we'll get into in webinar 3, is optimizing estradiol levels. The higher the estradiol, the more the flip you'll see in your lipids and an increase in HDL. Yeah, I know, I said it correctly. I know nobody knows that or understands that, but that's reality, and I'll show you those studies. And that's what you typically get with injectable, is that you get extremely high levels that will increase your estradiol levels quite high. Yeah, it may cause nipple tenderness. We'll then lower the dose for a while. But when you get the levels that high, you'll see a flip in the lipids, and then you'll see a decrease in visceral fat, and then you'll see improvement in cardiovascular disease and a decrease in inflammatory markers. You will not see that unless you get your level up high enough. Keeping levels in that mid-range, completely worthless. But that's what everyone does because they don't understand the studies or really have the clinical experience with it. Excellent. Well, thank you. Do I look at DHEA serum levels and optimize in coordination with testosterone? Yeah, DHEA does have a separate effect beyond and above converting into testosterone. If you look at the studies and you have any experience with using DHEA, you can use a relatively high dose of DHEA and not budge testosterone levels in men. They will budge up, they will go up in women, but they typically do not cause an increase in testosterone in men. But yet you'll see many beneficial effects of DHEA on mood, visceral fat, cardiovascular disease outcomes, et cetera. So yes, I do prescribe DHEA. There's hundreds of articles in the literature showing beneficial effects of adding DHEA to the hormone regimen. Hi, Neil. Wondering if you would part with your slides. I have to go through Dana in order to do that because they're owned by Worldlink Medical because they prepared them. Thank you for taking the time to help continue to educate us docs out there trying to help improve our patients' health. Thank you very much. Yes, that's my passion. Even though I'm just an ER doc, I still want to make sure that everyone is well educated and knows the importance of optimizing their health. And I simply do that by looking at all the different articles that show beneficial effects. R2 Labs Access and AEL lists the total free testosterone range for women between the ages of 30 to 60 as the same. The only other options are 0 to 29 for the norms. I would use the 0 to 29 then level. I have a male patient who's been experiencing clots. His baseline testosterone is in the 200s. With Q weekly injections, we have maintained around 600. You're maintaining at 600 because you're not measuring it soon enough. If you measure it on day 1 to 2 to 3, you'd see the levels up around 2 to 3,000. As you can imagine, the PCP and hematologists want to DC as soon as possible. Yes, I would DC the testosterone. You have two choices. If they're going to continue to see the PCP and the hematologist, then you have to decrease, you have to stop the testosterone. And then the patient says, yeah, but I feel like crap. And I say, well, that's too bad. Ask your doctors what to do about it. Or choice 2, the patient can then not see the PCP or the hematologist. Well, they're going to have to see the hematologist because they've got persistent clots. So I don't have a good solution for this other than if it was me, I'd continue to take the testosterone and understand and realize that the other PCPs and hematologists do not understand that the testosterone does not cause clots. But they've read that it does, and therefore you have to go with that. Please use a description of hard evidence when referring to testosterone evidence. Yeah, I should use hard evidence because a lot of the studies look at soft evidence, which is, as I said, self-reported. I got dizzy, I had vertigo, okay, then you had an event. I got lightheaded and passed out, you had an event. I got edema, you had an event. And those get listed as harmful events. And if you don't read the study, you will not know that. Lowell Barrick says, will testosterone induced peripheral edema require chronic diuretic? No, it tends to go away with time. I don't treat it, it goes away. If you look at the studies on treating men with testosterone that have congestive heart failure, there's an increase in cardiac output and actually a decrease in edema. But they're already on diuretics, so it really doesn't matter. But the edema is transitory, usually lasts a month or 2. You can treat it with a diuretic if you want. I tell patients just to ignore it. Does testosterone-induced edema require prolonged diuretics? No, it's self-limited. Thank you for thanking. Is there any article that addresses the rate at which one can safely raise testosterone levels when trying to optimize the patient? No, I don't think there's an article that looks at the rate of going up. I just give them that therapy straight off the top. I don't go up slowly. If you want to go up slowly with thyroid, you can, but with the testosterone and other hormones, I just go up right away. Could you please explain why men with low testosterone get hot flashes and cold sweats? Men with hot flashes and night sweats have a temperature dysregulation from the hypothalamus, just like women that lose estrogen. But not all men and women that sweat have low hormone levels. They can sweat for other reasons. They can sweat because of their REM sleep. They can sweat because of other issues. But if they're truly sweating, make sure they don't have TB or cancer or something else that's causing their night sweats. Is it the FSH and LH surge or estrogen testosterone balance? I don't think so. I think that's just people that weigh more, that have more body fat or more BMI or more subject to sweating, people that are thinner and have less BMI typically tend not to sweat. So I think it has a little bit to do with a body mass index and total fat, in addition to hormones. Is there any evidence to suggest it's harmful to suddenly increase testosterone levels? No. Meaning to see them go from low levels to high normals or optimized levels within a few weeks or days? No, not at all. That's what everyone does. Do I still recommend blood testing 5 hours after topical application of testosterone? Yes, I do. If you get numbers that you don't like, then retest it and don't take it on the morning of the test. That way the numbers will be low and everyone will get a number that you like. Are there any situations where testosterone is contraindicated or will be harmful to the patient? Do not treat anyone with an active prostate cancer. 1 in 7 men have an active cancer right now that you're treating and you don't know about, but don't treat anyone with an active cancer because it will really upset your oncologist and urologist. Question, testosterone treatment and edema, can testosterone therapy cause edema? Yes, absolutely, in 25% of people. I feel like I may have seen this, very rare, but a few guys have said that they've noticed a little bit of edema. Yes, absolutely. I'm not sure that where to go with these patients. Just advise them that it is due to an increased reabsorption of sodium in the distal renal tubules. It will cause fluid to come along back with it and increase a little bit of edema. It's usually transitory, goes away in a month or 2. If it's an issue or concern, use Maxide 7550. If it's not a concern, just ignore it. It tends to go away with time. Okay, let's see what else we got. sarcasm, hard evidence and testosterone, you are at times sarcastic. Just saying. Me, sarcastic, I'm never sarcastic. Am I sarcastic, Dana?
No, of course not.
Okay, good. Those that know me say I'm not sarcastic enough. Those that don't know me say I'm just sarcastic, but nevertheless, yes, I'm sarcastic. But I'm sarcastic because I have to be to sort of poke fun at us or to poke criticism at us, because why we do what we do and why we say what we say is not necessarily based on pure medical evidence and literature support. And that's why I'm sarcastic, only because I'm sort of making fun of ourselves as opposed to, you know, trying to be sarcastic to a certain group of individuals, because I was taught and trained the same way. But nevertheless, the medical literature supports the opposite. Any great documentation or lack of association between DBTs and testosterone that we can reference? I can't give it to you right now, but I'll give you a whole lecture whereby you'll see all the studies showing no adverse effects or increased risk, and I'll show you a couple studies where they claim that there was an increased risk, but you can't really make those claims because that was an association and was not a causation. How long does it take to regain normal sperm counts in younger men? Probably about 3 months, and you can use HCG to help with that. For a non-internist or cardiologist treating men at high risk or history of MI or angioplasty, do I recommend referral for updated cardiovascular workup prior to starting testosterone for the medical record? Yes, you sure can. And when you do so and send the patient to a cardiologist, they will probably recommend not using testosterone. And if the cardiologist doesn't recommend testosterone, then don't use it. Prostate cancer risk effect with testosterone? No, not in any study in 50 years. Okay, that concludes today's session. Sorry I ran over, but I hope it was beneficial for everyone. We'll look forward to seeing everyone at the next webinar. I'm going to present more of the same articles, but a little bit more detailed, but also get into the levels of testosterone and criticize the current recommendations for maintaining lower levels when we treat, and the criticism on not treating anyone if the level is not over 300. Thank you, Dana. Thank you, Chris, and we'll look forward to everyone at the next webinar in a month.
All right. Thank you, everybody. Just wanted to let you know that we will be sending out a PDF version of this presentation along with a copy of the webinar recording. In addition, I do have the full text articles. I would just ask that you ask me for them individually, and you'll be able to do that once I send out an email with the PDF version of this presentation. I hope you all enjoyed it. Again, this is webinar 1 of a series of 5 on this topic, so be sure to watch for more invitations coming in 2016. Thanks for listening. Those of you who haven't attended a WorldLink Course 1, we hope to see everyone at our next Part 1, January 29th through 31st in Salt Lake City. And as always, feel free to explore the resources available on our website. Thank you again, and have a great day.
You should probably advise them that I'm going to be sarcastic.
Okay, I'll warn them that in the next time. Bye, everybody.
Bye-bye.